Good morning. It is 10:59. We have 193 attendees, and we plan to begin just about 1 minute. Just turned 11 o'clock. I'm going to give it one additional minute. People are still streaming in. Good morning. It is 11:01. We currently have 228 attendees, and we're going to go ahead and begin the webcast at this time. We are live and recording. Today is April 1st, 2020, and this is our third in a series of weekly calls for Medicaid behavioral health providers that seek to provide verbal updates on our response to the COVID-19 state of emergency and our associated guidance. My name is Dr. Alyssa Ward. I am the Behavioral Health Clinical Director at the Virginia Department of Medical Assistance Services. We appreciate you being here with us today. This is our first week attempting this call via WebEx event format. What that means, as you can already tell, is that all of the participants in this call are automatically muted. The chat function is still live and you are able to submit questions through that chat function. We hope that this will alleviate some of the issues that we had last week with participants and background noise. In a WebEx event, you should also be able to use a menu to, for example, give applause or do laughter. Hopefully there will be less need for that laughter as we will have less background noise. It's possible to listen into this event over the phone, but we do encourage participation on your computer as well, as we will start to include some slide content today. And we continue to pursue options for posting these recordings on our webpage. We want to continue to start off each of these calls by expressing our gratitude to all of you for your collaboration and your feedback during this unprecedented and challenging time. We appreciate all the hard work you're doing to continue to provide care for those that we serve together. We are receiving a high volume of calls and emails seeking information, and we would like to start by referencing the 2 DMAS memos that we have released providing guidance on provider flexibilities. These are both available on the DMAS website and through the portal. We're working on a frequently asked questions document as well and are hoping to have that loaded to our website this week. I'm joined again today by Dr. Cleopatra Booker, our Senior Program Advisor in Behavioral Health, and Ashley Harrell, our Senior Program Advisor for our Addiction and Recovery Treatment Services, as well as Laura Reed, who is the host for this event and our Behavioral Health Manager. For those of you who are on the computer, you can see that we do have an agenda pulled up at this time. And on today's call, we will be providing a review of the guidance document, Behavioral Health and Arts Provider Flexibilities Related to COVID-19, which was released on March 27th, and provides further clarification on provider flexibilities related to the delivery of behavioral health services, including substance use disorder services. I'd like to start this call by reviewing the preliminary results of our telehealth survey that we initiated last week. We appreciate those of you who are able to participate in this quick survey, and we know everyone's time is extremely valuable right now. If you're at your computer, you'll be able to see these preliminary results on slides. So I will thoroughly narrate the content of these slides for those of you who may not be able to see them. See, the slides are up, and so we can move to the second slide. In this survey, we have received 19 preliminary individual responses that represent 17 individual agencies. And 95% of those respondents were providing mental health services. 58% were also providing arts services. And then 26% were additionally providing some type of other service. Those include IDDD services, early intervention, opioid treatment providers, and residential services. We asked in our survey if the agencies responding were currently using a telehealth platform, and of those 19 preliminary responses, 89% were indeed using a telehealth platform. That's 11% not using a platform. And 32% of those using the platforms were using Zoom. 16% are using Google Meets, 10% are using WebEx, 10% using DoxyMe, 5% using Notable, 5% using Microsoft Teams, 5% using Polycom, and 5% using Loris Online. We also asked if agencies would be interested in receiving potential free access for the use of a telehealth platform during our state of emergency, as that's something that we are exploring and seeing whether it's possible for DMAS to pay for that. We did find that 79% would appreciate free access, 21% said no. We also asked for information on barriers of implementation to using telehealth platforms. As we know, there are quite a few. 89% of respondents indicated that members not having a compatible device was a primary issue. 79% said no internet access is a barrier. 74% endorsed weak or no cell phone service. 37% indicated that members may just not be available or interested in virtual visits, and then 32% wrote in some other responses. Those other responses included things like provider availability of equipment for telehealth, such as webcams or tablets. Increased use of telehealth creates technology difficulties with these platforms. We heard a lot about that from providers in the first week of the crisis, where some of the platforms were crashing. And then limited data on client cell phones. This is, of course, preliminary. We know that at this point there are 378 of you on this phone, and so we want to open this survey up, of course, to anyone who's interested in providing feedback. We will keep that survey live until this Friday at close of business, April 3rd. And the link is provided on the agenda as well as on your screen at this time. I'm going to hop back over now to talking about our kind of general and global issues. We've received a lot of questions about member access to telephones, which is relevant to that data that you just saw, as well as additional minutes and data. And we just wanted to note today on this call that the Medicaid health plans, the managed care plans, may cover these phones as an enhanced benefit to their members, cell phone access, and are utilizing either SafeLink or Assurance. Members who have access to these benefits currently have unlimited cell phone minutes for April through mid to late May as a result of the state of emergency, and apparently also have some extended data options. So we encourage members to reach out to their health plans member services if they're in need of that enhanced benefit or have questions about it. And before we move on to the specific flexibility guidance, I do want to make a few global statements about the process we're undergoing right now and some common questions we're receiving about DMAS activities at this time. I did want to make a note that DMAS employees are all deemed essential. We have around 700 employees at DMAS, and we are all working from home at this time. So our work phones are forwarded to our cell phones, and we all have capacity to conduct our work from home. We are teaming very well together. I'm very, very proud of our behavioral health division and their incredible efforts to remain productive and responsive and dedicated to our mission, while also balancing the demands of caretaking for a variety of forms of caretaking during this crisis. And we have a very special group of public servants. I want to thank and acknowledge them on this call today. Many of you know that Virginia is in the process of applying for an 1135 waiver to CMS that would potentially grant us temporary permission to waive or modify certain Medicaid and CHIP requirements to ensure that sufficient healthcare services are available to meet the needs under a state of emergency. The full waiver has not been submitted, contrary to some things that you may have seen online, and we are currently working through the application in collaboration with other state agencies, our attorney generals, and our secretariat. We will be providing updates as possible about that 1135 waiver on this call, but there will also be an associated blast memo that will go out to all Medicaid providers once that 1135 is submitted and approved. DMAS has a COVID-19 specific section of our website that includes one-pagers and documents that may be helpful to members and providers, including some member frequently asked questions, and we would suggest that you check that out as a reference point. We assure you that we're working in partnership with other DMAS divisions to ensure that Magellan, BHSA, and our MCO contractors are following the guidance issued to them regarding these flexibilities, and we appreciate your feedback. The more specific, the better. When you have concerns that there's any potential lack of alignment or compliance, and we escalate those concerns to the divisions that manage those contracts within DMAS. I want to take a moment today to talk a little bit specifically about therapeutic day treatment. We continue to receive a really large volume of questions and feedback about these policies and flexibilities. And within that feedback, we've heard from TDT providers regarding concerns about the functioning and survival of this service during the COVID-19 state of emergency. And specifically, some providers have expressed concern and desire for clarification around guidance that healthcare providers, including behavioral healthcare providers, are indeed essential workers, and that the governor's declaration has allowed for groups of less than 10 to convene together. DMAS guidance has sought to be as reflective and responsive to protecting the safety of our members as possible. While child care centers have remained open for essential workers, we just want to be really clear that therapeutic day treatment services are not child care services. They are healthcare services. And our guidance around limiting social distance and prohibiting group delivery of outpatient and community-based services is across all services in behavioral health and not specific to DDT. This guidance was issued with best medical recommendation at this time to use alternative methods of service delivery. Thus, we've opened up the location for these services outside of school or office or clinic settings to allow for home-based delivery in cases where providers and families are comfortable providing those services individually in face-to-face scenarios. Further, all these services are now available via telehealth or through audio-only telephonic communications. And DMAS is allowing TDT to function and deliver services in various ways, which are usually prohibited. Intensive in-home is an approved in-home behavioral service with similar interventions as TDT for a similar population. Intensive in-home clinicians have protocols and procedures in place for working in the home, and they've been established in relationships with families in their homes. And intensive in-home is arguably better equipped to continue in-home services since this is their usual business as usual model of care. TDT provided in the home alongside intensive in-home in the home is a duplication of services, and a duplication of services is not allowed by CMS. So even if the person is receiving intensive in-home, if you follow our guidance technically, TDT can be provided via other means of delivering the service through telehealth. So that is, if an intensive in-home provider is in the home still, the family is comfortable with that, the provider is comfortable being in the home, and they are doing that, TDT could continue as a telephonic or telehealth service, technically. But it would be very important that the two different providers would be in communication and would be talking about how their treatment plans interrelate, and that they are coordinated together and that there aren't kind of overlapping goals in place. DMAS has also allowed TDT providers to receive reimbursement for 1 unit per day if they're only able to complete a telephonic contact. And that's regardless of the amount of time on the phone, instead of being required to complete the 2-hour minimum of service a day to get 1 unit. We also want you to note that the DBHDS functional and operational guidance for providers also specifies that group day programs should not continue in typical format. That is, groups from different households congregating together. And that guidance is available on their website. We've been working really closely with our DBHDS partners to try to assure strong alignment across our recommendations and guidance. So TDT is still allowable via telehealth or in the home for the next 120 days as stated in the guidance issued. We know that you have concerns about the provision of some services with their current units, such as ICT, and we assure you that this entire process is continuing to evolve. We are continuing to evaluate the flexibilities that we are granted, and will thereby continue to update our guidance as rapidly as possible. I'm now going to turn to our next panelist, Ashley Harrell, who's going to speak to the guidance offered in our most recent memo on addiction and recovery treatment services. Ashley?
Okay, thank you, Dr. Ward. Good morning, everyone. This memo is part of a series of memos that sets out the agency's guidance on flexibilities available to providers in light of the public health emergency presented by the COVID-19 virus. This memo includes clarifications and changes from the text of the March 19th memo that's titled Provider Flexibilities Related to COVID-19. It focuses on behavioral health and addiction and recovery treatment services, as Dr. Ward mentioned earlier. These changes affect both fee-for-service and our managed care organization models of care. However, before I discuss the updates in the memo in relation to the ARTS benefit, I want to announce that as of yesterday, March 31st, the U.S. Department of Justice issued guidance that the Drug Enforcement Agency, or DEA, in partnership with the Substance Abuse and Mental Health Services Administration, or SAMHSA, new allowances to ensure authorized prescriber or practitioners may admit and treat new patients with opiate use disorder during the public health emergency. The DEA has already announced that practitioners may prescribe controlled substances to patients using telehealth or audiovisual means without first conducting an in-person evaluation during this public health emergency. Yesterday, the DEA stated that practitioners have further flexibility during the nationwide public health emergency to prescribe buprenorphine to new and existing patients with opiate use disorder via audio only or telephonic by otherwise authorized practitioners without requiring such practitioners to first conduct an examination of the patient in person or via telehealth or audiovisual means. This additional flexibility under which authorized practitioners may prescribe buprenorphine to new patients on the basis of a telephonic evaluation is in effect from March 31st, 2020 until the public health emergency declared by the Secretary ends, unless the DEA specifies an earlier date. This next alert was not noted in the DMAS memo, but is of significant importance. SAMHSA issued guidance in regards to the public health emergency and 42 CFR Part 2. The guidance is to ensure that substance use disorder treatment services are not interrupted during the public health emergency. Since many services are being delivered through telehealth services as well as telephonic communications to patients who may not have access to smartphones or broadband, providers may not be able to obtain written patient consent for disclosure of substance use disorder records. Thus, the prohibitions on use and disclosure of patient identifying information under 42 CFR Part 2 does not apply in these situations to the extent that, as determined by the provider, a medical emergency exists. SAMHSA states that under the medical emergency exception, providers may make their own determinations whether a bona fide medical emergency exists for the purposes of providing needed treatment to patients. And this information is located on SAMHSA's website under the COVID-19 section. Now I'll move to the specifics of the March 27th memo that highlights the clarifications and changes to the ARTS benefit. DMAS is reinforcing in this memorandum that Medicaid allows a member's home to serve as the originating site. This is particularly important for those who are quarantined, are diagnosed with or demonstrating symptoms of COVID-19, or at high risk of serious illness from COVID-19. Clinicians shall use clinical judgment when determining the appropriate use of home as the originating site. Please know the originating site fee will not be available for reimbursement, nor is DMAS requiring a telepresenter or other staff to be present with the member when home is the originating site. Providers shall document when services are delivered through telehealth or telephonic means. DMAS recognizes that providers may not have access to their offices, the member's medical records, or other team members during the state of emergency. Thus, providers shall update documentation and treatment plans. This includes the Interdisciplinary Plan of Care, or IPOC for preferred OBOTs, with at the minimum a notation that verbal consent was obtained from the member, as well as other team members as appropriate. Providers shall make reasonable attempts to obtain appropriate physical signatures within 45 days after the end of the state of emergency. Team members' verbal consent shall include the name of the clinician, as well as the date the verbal consent was obtained. If providers are delivering treatment through telephonic or telehealth only, they shall document in the member's medical record the method of delivery. Also for ASAM levels 2.1 and higher, which require service authorizations, any new or subsequent service request authorization submissions shall include the mode of service delivery. Another update in the March 27th memo is, in accordance with the Board of Medicine, Medicaid allows for physicians who are actively licensed in states that may be bordering Virginia, but who are not licensed in Virginia, to be able to continue to see their Virginia resident patients via telemedicine, telehealth, or telephonic communications, so that members can continue to receive their buprenorphine prescriptions. The Board of Medicine does require that physicians must have an established relationship with the patient to meet this allowance. This memorandum also clarified the 14-day grace period for the submission of service authorizations for ASAM levels 2.1 and higher. So our Medicaid managed care organizations, as well as Magellan of Virginia, will allow up to 14 days after the start of a new service or after the expiration of an existing service authorization to be submitted from the provider to the managed care organization or Magellan of Virginia. Note that this grace period does not waive medical necessity requirements for the services or other requirements currently set forth in policies for submissions of service authorization requests. For ASIM levels 2.1 and 2.5, so this is intensive outpatient and partial hospitalization programs, if providers are unable to provide the minimum amount of services required for the reimbursement of partial hospitalization or intensive outpatient, providers may bill psychotherapy, assessment, and evaluation CPT codes. Thank you to your feedback. We also clarified in this most recent memorandum, under the state of emergency, if a certified substance abuse counselor or CSAC or CSAC supervisee are performing substance use disorder counseling as within their scope of practice, DMAS is waiving the requirement for only licensed practitioners to bill the psychotherapy codes. CSACs and CSAC supervisees will be allowed to bill the most appropriate psychotherapy code based on the amount of time spent performing the service. They would bill under their licensed supervisor, National Provider Identifier, or NPI, and document the reason for billing the psychotherapy code by the CSAC or CSAC supervisee, which is due to not meeting the minimum time or being able to bill the per diem for IOP or PHP. DMAS has also clarified that individuals who have not participated in a service within 30 days, they do not have to be discharged from the service. If the service authorization period ends, however, a new authorization request shall be made for the service to continue. In regards to ASIM levels 3.1 and above, so those are residential as well as inpatient services, DMAS clarifies that the requirement for prior authorization still remains, but the 14th grace period that I discussed earlier applies. Providers shall refer to guidance from the Centers for Disease Control regarding best practices for facility settings. If members need to be quarantined because they are ill, the provider should coordinate their efforts with the Department of Health. More information can be found on the Virginia Department of Health website. If individuals need to be quarantined and hospitals are attempting to step them down to a lower ASIM level of care, we encourage providers and clinicians to evaluate the appropriateness of this transfer or step down. Also note that service authorization requirements, as well as medical necessity criteria, will have to be met for admissions to these levels of care. Now, looking at our opiate treatment programs and preferred office-based opioid treatment services, as well as providers of medication-assisted treatment. DMAS emphasized that individuals with opioid use disorder may have high-risk comorbidities, such as chronic obstructive pulmonary disease, cirrhosis, or HIV, that may increase the risk of severe disease related to COVID-19. In light of the potential risk of exposure to COVID-19, as well as barriers to accessing treatment due to illness, quarantine, the risk of serious illness, DMAS asks providers and staff to exercise clinical judgment to prioritize the continuation of members' medication for the treatment of opioid use disorder. In line with the updated national practice guidelines issued by ASAM, DMAS is instructing providers of medication-assisted treatment to not delay the initiation or continuation of medication due to a member's inability to see medical or behavioral health clinicians face-to-face. DMAS expects that preferred OBOTs and OTPs remain open and accept new patients interested in medication-assisted treatment initiation during this time. If a provider, a preferred OBOT or an OTP is at member capacity for medication-assisted treatment services, the preferred OBOT or OTP should have procedures in place to connect individuals with care. DMAS is especially mindful of the mental and emotional duress that may be experienced by Medicaid members, as well as potential disruptions in illicit drug supply that may encourage individuals to seek treatment, and the importance of initiating medication-assisted treatment during this time. DMAS echoes SAMHSA and the DEA regarding the allowance of and recommendation of the use of telehealth and/or telephonic services to provide evaluation and treatment of patients. These resources can be used for initial evaluations, including evaluations for consideration of the use of buprenorphine products to treat opiate use disorder. OTPs and preferred OPAT providers are essential medical services. Thus, providers shall be making efforts to assure current members have access to life-saving medications in accordance to the DMAS memos. Providers shall also be making necessary arrangements to serve new members who are in need of initiation of medication-assisted treatment. DMAS has recognized that members may not be able to pick up their medications from opiate treatment programs during this state of emergency. So with the most recent memorandum, DMAS allows OTP providers to deliver the medications to the member's location and be reimbursed for this service. We have set up for a delivery of up to a 2-week supply to bill 5 units of H0020, which equates to $40 or about 70 miles round trip. And for delivery of 3 weeks or greater, up to a 28-day supply, OTP providers can bill 10 units of H0020, which equates to about $80 or 140 miles round trip. However, DMAS is also considering the impact of take-home dosing for opiate treatment programs and is looking at other potential changes. DMAS clarified in the March 27th memo that buprenorphine, which is a scheduled free medication, is now covered at a maximum 90-day supply. Please note that drugs dispensed for 90 days are subject to a 75% refill too soon edit, which means that members will have to have used approximately 68 days in order to be able to get another refill. DMAS supports providers following the ASAM National Practice Guidelines for the Treatment of Opiate Use Disorder 2020 Focus Update. These updated recommendations aim to support the initiation of buprenorphine treatment in the emergency departments and other urgent care settings. Please note that all assessments do not need to be completed before initiation of pharmacotherapy for opiate use disorder. In addition, ASAM guidelines provide greater flexibility on dosing during the initiation of buprenorphine treatment and for initiation of buprenorphine at home, which is significant in the midst of the COVID-19 crisis. If your prescribers are not able to continue to prescribe to members or are reaching their SAMHSA patient limit for prescribing buprenorphine, please contact the member's managed care organization, ARTS Care Coordinator, or email sud@dmas.virginia.gov. We do have alternatives to ensure members have access to their medications. To support behavioral health and medical providers adjusting to telehealth service delivery, a changing policy landscape, and the heightened anxiety experienced by members and providers during this time, DMAS is offering several web-based learning opportunities conducted by expert consultants. Paul Brassler, who is a licensed clinical social worker, is providing 2 sessions for tele-behavioral health on April 2nd, tomorrow at 11, and April 3rd at 1 o'clock. We also have Dr. Mishka Turplin providing 2 separate sessions focusing on prescribing medications for opiate use disorder via telehealth, and he will be presenting tomorrow, April 2nd at 9:30, as well as April 3rd at 3 o'clock. Please email sud@dmas.virginia.gov if you need links to these live webinars. We will also be recording the webinars so that can be viewed at a later date. And with this, I will then pass it over to Dr. Booker. Thank you.
So
Good morning, everyone, and thank you, Ashley and Dr. Ward, for kicking us off today. A lot of what I'm going to go over is very much related and in conjunction with what Ashley went over in regards to arts. It's just specific to some of the behavioral health services. I want to remind everyone, participants, that we are aware that when you only send a question to the panelists, the rest of the participants do not get to see your question. They only get to see the responses that we're sending out. So if you want to make the questions seeable by everyone that's on the phone call, all 417 participants, you would have to make sure you select that you're sending the question to all participants, and then we'll send the responses back out as much as possible. Additionally, although we are monitoring the chat function, there may be some questions that we're just going to take back as they start to increase and roll in, and we'll be putting those on our FAQ documents that we are drafting. I would also like to reiterate that for any services that we do not specifically talk about today or that are not specifically called out in the memo, face-to-face service requirements are not necessarily required for those, but documentation shall continue to justify the rationale for service through a different model of care. So for example, in the memo, we do not specifically call out psychotherapy or psychological testing. We include that in assessments, but all of those, we are not requiring that it be done or completed via face-to-face, as with all of the services that we put in the memo. Within the new guidance, you will see that we have reminded providers to continue to provide interventions and formulate responses to COVID-19 guided by trauma-informed care principles. That includes trustworthiness, equity, choice, collaboration, empowerment, and safety. As we know that COVID-19 is impacting even the mental health professionals, we could only imagine how it may be impacting those that have a traumatic background. So we encourage providers to consider these principles as they navigate the implementation and flexibilities outlined in the guidance that have been set forth by the state. For all of the behavioral health services, such as assessments, psychotherapy, CMHRS services, et cetera, DMAS is allowing a member's home to serve as the originating site for members. So that means that the individual can be at home. They do not have to go to a clinic, as well as the person that is providing the service does not have to be at home, but if they have confidentiality and the capability to do telehealth via home, then the individual physician clinician delivering the service can also be at home. This is particularly important for those who are quarantined or diagnosed with or demonstrating symptoms of COVID-19 and or are at high risk of serious illness from COVID-19. Clinicians shall use clinical judgment when determining the appropriate use of homes as the originating site. I am aware that there was a question in regards to what do we consider as clinicians. Our QMHPs consider clinicians. QMHP shall also be using their judgment and clinical judgment when determining the appropriateness of a home as an originating site. And please note that QMHP shall also be licensed by a licensed mental health professional. So that licensed mental health professional should be in contact with their QMHP to make sure that they are all in agreement in regards to the use of telehealth for certain populations. More regarding telehealth. If providers are delivering treatment through a different method than normal, this shall be documented in the member's medical record and in any new or subsequent service request authorization submissions, it should be documented. DMAS also recognizes that providers may have limited or no access to their offices and members' physical records or other team members, that this may create a barrier to obtaining necessary signatures on documentation. Thus, providers shall update documentation and treatment plans, including individual service plans, interdisciplinary plans of care, and at least notate that the verbal consent was obtained, and providers shall make reasonable attempts to obtain appropriate physical signatures within 45 days after the end of the state of emergency. In regards to obtaining clinician signatures on relevant documentation, each provider shall make reasonable attempts to obtain signatures from the clinicians or document receiving the clinician's verbal consent or sign-off. with the name of the clinician and the date of receipt. If the clinician is unable to sign off on the documentation, the clinician shall maintain documentation of verbal consent or the actual sign off of the information within their own files. There has been some questions around licensure reciprocity. So for the areas that we could clarify within the memo, we provided a little bit of clarity that licensure reciprocity or the allowance of other licensed clinicians to be able to see Virginia members are currently actively in discussion with DHP, as Dr. Ward went over in the beginning. But in the meantime, we want to note that Virginia Medicaid allows for physicians, those licensed to practice medicine, who are actively licensed in states bordering Virginia, but not licensed in Virginia, can continue to see their Virginia resident patients via telemedicine and telehealth or telephonic communication so that members can continue to receive their prescriptions. The Board of Medicine requires that physicians must have an established relationship with the patient to meet this allowance. Particularly in the new memo that was released, we provided some clarification or some relief for providers in regards to authorization. Within the most recently released guidance, we added an authorization timeframe allowance. With this, it allows a 14-day grace period for the submission of behavioral health authorizations to include CMHRS, assessments, psychotherapies, inpatient treatment, and ARTS levels of care. This means that the MCOs and Magellan of Virginia will allow up to 14 days after the start of a new behavioral health service or after the expiration of an existing authorization for a service authorization request to be submitted from the provider to the MCO or to Magellan of Virginia. Please note that if you are waiting 14 days to submit an authorization, you cannot submit a claim prior to that authorization being given to you. If you submit a claim prior to receiving an authorization, you may very well so end up getting your claim denied because the service is not authorized. So if the provider is choosing for business reasons or care reasons to not submit the authorization until after the start of the service, it is very important to note that you cannot submit a claim for any of the services, including the ancillary services that may occur within an inpatient setting, until you receive an authorization or the claim will most likely deny. Regarding some specific service guidance, the time frame for how long TDT, intensive in-home, mental health skill building, psychosocial rehab, and ICT providers can deliver services via an alternative method has been extended to 120 days. Service delivery may be provided outside of the school setting, office setting, or clinic setting for the next 120 days. Please note that the authorization processes remain intact, so you must still require an authorization to continue services or to start services. Regarding discharging individuals, DMAS is allowing individuals who have not participated in a service in 30 days. They do not have to be discharged from the service. If the service authorization period ends, a new authorization request shall be made for the service to continue. This flexibility was implemented as we know the current crisis situations may create times when members are not in contact or active in the service for a period of time due to a variety of factors. We made one additional addition within the memo for behavioral therapy. The guidance now indicates that behavioral therapy or ABA services where a physician letter was required or a physician's referral determination was required, it is not required at this time for submission prior to the authorization. The MCL shall review the request and make a determination without the physician referral. However, please note that the physician referral or letter of determination shall be completed within at least 60 days of the start of the service. We've added a section for crisis stabilization and crisis intervention services as well to further clarify that crisis services can be done via telehealth at the clinician's discretion. For members in residential levels of care, including therapeutic group homes and or higher medical necessity can be waived for continuation of care if the individual is unable to transition to lower levels of care due to COVID-19 and quarantine. If an individual is currently within a psychiatric residential treatment facility or a therapeutic group home and requires acute or inpatient medical treatment, non-psychiatric, for more than 7 days, the authorization will not be ended for that PRTF or that TGH. And the individual does not have to be discharged from the residential treatment facility or the group home. For any subsequent admissions back to the treatment facility or the group home, the previous admission authorization can be extended. If you are a facility-based provider, we encourage you to refer to guidance from the Centers of Disease and Control regarding best practices for facilities. Additionally, if members are needing to be quarantined because they are ill, the provider should coordinate their efforts with the Department of Health. And more information can be found on the Virginia Department of Health webpage. That concludes all of the updates. And if you have any additional questions about the behavioral health specific portions of this memo, you may also email your provider association, which has been doing an awesome job at funneling questions to us. Or you can email enhancedbh@dmas.virginia.gov. And at this time, we have about 14 minutes left. So I'm going to hand it back over to Dr. Ward as we attempt to answer any questions. Ashley, myself, and Dr. Ward will be on the line as we attempt to answer any questions in the chat function that has not already been answered.
Thank you, Dr. Booker. We are tracking the questions as they are coming in, and I am looking to see if there are some within this box that we may be able to respond to verbally on this call. Just to be clear, there have been a number of questions from folks who were not able to join at the 11 o'clock start. To clarify, the only slides that accompanied this presentation were the agenda and the telehealth survey slides. The rest of this content was delivered verbally. We don't plan to release a script or summary of the verbal comments, since these verbal comments are meant to accompany what has already been written. Though, as we've indicated, we are turning a lot of the chat conversation here into our frequently asked questions document, which will be posted. We are looking at capacity to post the recording of this call on the website if you were unable to listen to the entire call. We are also seeing some questions about behavioral health providers as essential workers and whether DMAS will be issuing essential worker letters. We really cannot respond to that question right now. There are serious conversations going on across the agencies about what body is most appropriate, if any, to issue specific documentation, but we don't have that information to offer at this time. There are a number of questions in our chat from behavioral therapy providers. And indeed, as you heard, there is content on this call relevant to behavioral therapy. And there will be frequently asked questions integrated about behavioral therapy.
In regards to behavioral therapy and what services can be done via telehealth, any of the assessment services, therapeutic interventions, care coordination activities, treatment planning, any of that you deem appropriate that cannot be, done via face-to-face at this time could be done via telehealth. That was a question.
going through a number of the TDT related questions. There is a question in here about ID day treatment in residential settings that we'll have to defer. There are a number of questions about streamlining the process of authorizing intensive in-home when providers are seeking to move members from TDT into intensive in-home. We're aware of the need for that, and that is a conversation that we're having with the MCOs about how we can smooth that process. We'll report in on that as we find out more information about what that might look like.
At this time, we do encourage providers to continue process as usual. So if you are planning on just enrolling or getting someone intensive in-home and no longer doing TDT services, we encourage you to discharge the individual from TDT and then start intensive in-home. When you submit authorization requests to the MCOs, if they are not aware that someone is being discharged from one service, it may impact the determination. And so it would be very important to make that transition during this time as we roll that conversation into next discussion.
I'm also seeing a number of questions about when we anticipate that group settings would be allowable again. And I don't think that we can say right now. The best information that I have seen from my medical colleagues is that we are still a few weeks away from the heaviest point of infection here in Virginia. And so we really are, right now following those epidemiological guesses, hypotheses about what the landscape will be in Virginia. But as we all know, that's very hard to predict and depends upon the social distance kept amongst those of us that live here. And that our abundance of caution around trying to support the limiting of transmission in asymptomatic populations is why we have put the guidance in place to no longer provide group treatment and to move into alternative forms of treatment. I'm just going to put out there verbally on this call that I think, as a psychologist who's worked with large groups of children, I think there would be a lot of pragmatic challenges in getting numerous kids together in a room and maintaining 6 feet between all of those children for a duration of a number of hours. And we don't even know if that would be enough to stop transmission, asymptomatic transmission of the virus. So we really, these limitations that we've put in place are truly because we want to reduce the likelihood of our members, many of whom are very vulnerable already from being infected by the virus. And so we don't know when that will change, but we can say that everything that we're talking about in these memos, all of these flexibilities are all temporary. This is all during the state of emergency, and that we're working to be reflective of the administration's declarations, as well as in alignment with the guidance coming out from our sister agencies.
There is a request for me to repeat the licensure reciprocity piece that was stated. This was just noted that in regards to licensure reciprocity or the allowance of other licensed clinicians to be able to see Virginia members, We are in active discussion with Department of Health Professions to discuss this need and what needs to happen for this transition to occur. In the meantime, the guidance notes in the Medicaid memo, it allows for physicians, those that are licensed to practice medicine, who are actively licensed in states bordering Virginia but not licensed in Virginia. They can continue to see their Virginia residents via telemedicine and telehealth or telephonic communications so that members can continue to receive their prescriptions. The Board of Medicine requires that physicians must have an established relationship with the patient in order to meet this allowance.
We've also seen numerous questions both here and elsewhere about documentation of telehealth or telephonic platform. We want to emphasize again that clinicians should just put that in their note that the service that is being documented in that note was delivered by whatever method in response to the COVID-19 state of emergency. I guess I'll also note on this call that we've had questions from CSBs providing case management asking if they need to do a similar note to indicate that the telephonic delivery of case management was in response to COVID-19. That is not necessary if this is a service that you would typically deliver telephonically, which is pretty much restricted to that instance of case management contacts that are traditionally done by telephone. This is just for services that you have not delivered in the past via telephone or telehealth platform. And particularly around CMHRS services, which have not been allowed for delivery via those methods, but are allowed currently during the state of emergency. Give us a moment while we are taking a couple more minutes to review last questions to see what we can fit in.
There's a question for psychiatric residential treatment facilities and therapeutic group homes. If the member goes to detention or is on a runaway, do they need to be discharged according to the current residential manual? And the answer to that is yes.
I'm mindful of the time and we only have 3 more minutes on this call. I think Dr. Booker has one more response she can fit in before we end.
Yeah. There may be questions about how we incorporate residents, supervisees, and trainees in regards to telehealth. They should still be being supervised by their supervisors at the typical stance that they usually would receive their supervision on a daily or weekly basis. The supervisor does not have to be on site of where the resident is actually delivering the telehealth. So the supervisor and the resident in training does not have to be in the same room as the resident is delivering services through the telehealth platforms. But there should be continual supervision and documentation of that supervision and sign-offs or documentation of receiving verbal sign-offs and so forth as you usually would within the office setting.
All right, we thank you for your participation today. We appreciate your ongoing feedback and patience with us as we try to work as rapidly as possible to evolve our guidance. And we will be holding these calls every week during the state of emergency. And if If you would like to receive an invitation and did not receive one directly, you can email the enhanced bh@dmas.virginia.gov email address. We will continue to work on our frequently asked questions, and we look forward to visiting with you virtually again next week at 11 a.m. on Wednesday. Thank you so much.